All right. So as Sean Mawini said, so first of all, yes, if you're involved in CSL, you have to have the name Sean. So Sean Mawini, I'm Sean Amorati. But it's really great to have all of you guys here. This is the first time we've done a case competition at CSL. The response has been really tremendous from my perspective. Our goal next year is just something for you to know as you go back to your class to talk to your classmates. Our goal next year is to do even more around health equity, but also talk about equity in other areas as well, and have multiple different tracks for a case competition all on the same time. So we would have like equity and mobility in autonomous vehicles and urban settings, equity in healthcare, equity in energy, things like that. So our goal is just to kind of continue to advance this conversation around how bright folks like all of you can come up with solutions to really big problems in the world. And we were just blown away by the 50 submissions that we had from different students for the initial round. It was not easy to come up with the 10 finalists, but obviously all of you made it through, so congratulations. But really, truly, it was like an amazing response from our perspective. And so thanks for spending the time. Thanks for the thoughtful work. And we're excited to kind of hear your presentations today. I also just want to kind of acknowledge both United Healthcare and Optum Startup Studio specifically, because we wouldn't have been able to do this without their support. Like this literally just doesn't happen without their support. And Optum has been, and United Healthcare has been just an incredible partner to CSL for the last few years. Pretty much when we have ideas, Paul figures out a way to say yes, which I truly, really, really appreciate. So it couldn't have happened without them, and we have 3 judges from Optum and United Healthcare. And then I also want to acknowledge Kelly. Kelly is an entrepreneur here in Pittsburgh. I've known her since she went through one of our local accelerators a long time ago, and she now is running one of the life sciences accelerators here in Pittsburgh called LifeX. So it brings a great perspective to this conversation as well. Just for a moment on kind of the space that you're in here and kind of entrepreneurship at Carnegie Mellon. I know many of you are involved in the entrepreneurship programs back at the schools that you're part of, but just to give you a little bit of context, this is, although you're in our business school, this is actually kind of technically university-wide space. So we have entrepreneurs from all over campus here in the Entrepreneurship Center. I like to think that this is probably the nicest space on campus today, because like the Tepper building, the business school building that we're in here is our newest building, and arguably this is the nicest space in the newest building, which I think is a reflection on entrepreneurship today. When I was a graduate student here studying entrepreneurship 25 years ago, they had the entrepreneurship wing in a part of the building that you actually had to try to find. It was actually difficult to, it was kind of a closet, maybe slightly bigger than a closet, but like the world is different today, and I think that's a wonderful thing, because truly, from our perspective at Carnegie Mellon, I'm sure this is true to a lot of your schools as well. When we talk about entrepreneurs, we talk about people who look out into the world, see things that aren't the way they should be in the world, and then build products and services that fix those problems, right? And that's why we're excited to hear all of your ideas and your solutions around fixing healthcare today. But more people thinking about solving those problems, to me, is a wonderful change in kind of what graduate students are interested in studying. People now pick their graduate schools based on the quality of the entrepreneurship programs, and that was certainly much rare 25 years ago when I was a grad student here. So appreciate all of you coming in. The space here is called the Schwartz Center. That's because Jim Schwartz, and you can read a little bit about Jim if you're not familiar with him during the reception, but Jim is the founder of Excel Partners, which is arguably one of the 4 or 5 probably most notorious early stage venture firms in the world. You may or may not know the name Excel Partners, but you certainly know the companies that they've supported. So they were the first institutional check into Facebook, the first institutional check into Slack, and a number of other notorious early stage startups. And then the group that I'm part of is this group called the Corporate Startup Lab, which has been trying to, over the last 5 years, look at this question of, okay, if what entrepreneurs do is they look out into the world, see things that aren't the way they should be, and build products and services to fix that, how can we specifically help that happen, not only for brand new companies, not only for 2 or 3 person companies that start with small and have the goal of scaling up, but also for small projects inside larger organizations, right? So, if you think about the Apple iPhone, I would argue that's probably the most famous corporate startup of the last 20 years, right? Apple was a big company before the iPhone. It's a much bigger company today because of the iPhone. And it was, again, small group that became big. And so we've been looking at how do large established companies do corporate entrepreneurship? We've been focused on this for about 5 years. We've had a lot of collaboration with United Healthcare and their Optum group because in many ways, Optum is a corporate startup, right? And it's a $100 billion plus software business inside of the world's largest insurance company. And it was a group that started small and scaled up, and they're continuing to try to figure out how to solve the world's problems and build great solutions around that. I had the privilege of 2 weeks ago being out in Minnesota, which is where Optum is headquartered, talking to 200 of their most distinguished engineers about how they can go and solve those problems. And it was frankly like super motivating at the end of it to hear these people that are solving big problems. Because as all of you guys know, given the context that you've been part of here, healthcare is complicated. This is not like, building another app to get, food delivered to your door a little bit faster. Like healthcare is just it's a complicated ecosystem with a lot of players involved in it. And we believe that partnerships between innovative companies and groups like United Healthcare are essential to fixing those things. And they've created, and I think you'll hear a little bit more about this at the end, but they've created a program called the Optum Startup Studio, which partners with companies that are looking to deliver transformative innovation in the healthcare space, where you get not only some money from United Healthcare, which is incredible, but you also get paired up with subject matter experts and mentors who can help you work through all the regulatory risk and frankly, just relationships that you need often to commercialize that stuff. So that's the Optum Startup Studio. We hope that if some of these ideas turn into not only just great case competition submissions, but actually startups that you continue to work on, that you'd consider being part of that. And also, I'm sure Kelly at LifeX, if it fits in the life sciences space, would be happy to talk to you about that. I would say LifeX generally skews a little earlier stage than the Optum Startup Studio. So I think there's a nice natural progression from LifeX to the Optum Startup Studio and beyond. So that's a little bit about CSL, a little bit about the contest. I think just to finish one more time, I would just say, really thank you guys so much for doing this. I also want to just recognize the CSL folks who are here real quickly. So Sean Mawhinney, who you've all been interacting with a lot, has certainly made this happen. Also in the back of the room, Hallie Johnson, who's the other academic program manager. And then I have 2 of our CSL instructors here, so Melissa and Lou. So there's some CSL team that are kind of roaming around, and as you guys are eating dinner or whatever, feel free to chat with them a little bit more about CSL. But hopefully this was a great experience to date, and I really am excited for you not only just to give your presentation, but also to hear other student submissions. And while we can only have ultimately 3 winners, I hope that there's some opportunity for kind of peer learning and that everybody leaves finishing like this was a great experience. I think with that, we will hand it over to the first team.
What do you get when you prioritize the maternal health care for Black women, Optum's mission to address health equity, and a thoughtful technological innovation? You get Pardonly. I'm Dr. White, and my colleagues and I are thrilled to share with you how Pardonly is a solution to addressing health equity for Black mothers on their journey to motherhood. So I want you to meet Mrs. James. Mrs. James is a 27-year-old Black woman whose only medical history is migraines, who just confirmed to be 10 weeks pregnant. Mrs. James and her husband have been trying to get pregnant for 2 years. Her excitement for the pregnancy comes with a load of anxiety, though. She is currently between jobs and is living with her parents. And while she is insured under her husband's medical plan, she is unsure she can afford the co-payments for her prenatal care. She will be a first-time mother, so she doesn't know what to expect during her pregnancy or after she gives birth. What if she has an unexpected complication? She found an obstetrician that will take her insurance, but the office is an hour away from her home, and she will more than likely have to get there alone because her husband has conflicting work schedule. Mrs. James is financially insecure, has limited physician access, and a tenuous social support system. Look around you. Mrs. James could be our neighbor, our family member, or one of our closest friends. What could you offer Mrs. James that could give her some support during this exciting yet overwhelming time in her life. Partumly. With Partumly, Mrs. James would obtain additional support for her office visits, and in the future, she can think about giving back to other Black mothers on a similar journey as a Partumly advocate. But more on that later. Why is this support so vital? Because of the inadequate maternal health outcomes for Black women. Racial and ethnic disparities in maternal health predominantly impact Black women in the United States. Black women are 3 to 4 times more likely to die from pregnancy-related causes compared to other groups. And this extends up to 1 year postpartum with issues such as cardiopulmonary complications. And the cost of health inequity is expensive. In 2021, there were close to 550,000 births by Black mothers. The cost attributed to birth complications in Black mothers is about $488 million and growing. While there is literature that reports the benefits of having doulas and health coaches involved in the care of pregnant women, there are only 9,000 doulas and 6,500 health-certified coaches to service over 3.6 million births of all races. Still, the scope of the problem is not insurmountable. My colleague Mikhail will now go into Partumly's solution.
Many studies show that if you do have a doula by your side during the pregnancy journey, it can decrease C-section rates, along with lengths of the birth, and as well as overall stress and anxiety during labor. Partumly advocates provide that support throughout the entire maternity journey and really via a digital platform or whichever form of communication works best for the patient. We are not creating barriers. We are here to instead open doors for those who need support and then want to in turn provide support by becoming a Partumly advocate. One of the main access points would be a 2-sided app that creates community connections in a self-sustaining workforce development pipeline. So let's take a micro review of Mrs. James's experience. So first and foremost, it's really important to mention that throughout the entire experience, it has omni-channel engagement. And really what that means is just there's multiple ways to access your Partumly advocate. From, again, enrollment to engagement to then becoming an advocate. So Mrs. James is referred to Partumly by her provider. She then has an option to choose how she wants to engage and then who she wants to engage with. So think about this like picking a Peloton trainer. Mrs. James has choice. Mrs. James will then receive support throughout her confirmed pregnancy to 1 year postpartum, and Mrs. James can then take the opportunity to give back by becoming that Partumly advocate herself, a human touch powered by a digital interface. So a little bit more on our business model. Partumly utilizes a subscription model in exchange for a managed service organization, which provides end-to-end credentialing as well as RCM services for both doulas and health coaches. Partumly will not charge patients, and Partumly does focus on really 2 different plans. First, there is a discount plan for those advocates that are accepting Medicaid. For those that accept commercial and Medicaid, there is a standard plan at $125 per month. Oh, and the discount plan is $45 per month. These subscription plans do come with advocate training as well as other educational resources to really support the Partum advocate throughout their journey, helping patients to motherhood.
That Optum should partner with an existing company that's already building the networks, the technology, and the credibility in the community. A Black-founded startup such as Mommy or May are a natural fit. And Mommy in particular is interesting because not only is it building the networks of providers for Black mothers, but one of its angel investors is Serena Williams, who very famously had a terrible birthing complication through which she had to deal with significant dangerous provider bias. We think that with a minimal investment in a joint venture with one of these organizations, we could have a significant impact over a 5-year period. We see about 2,000 Partumly advocates using the platform by 2027, including 500 new health coaches or doulas that were trained by Partumly. That would equate to $3 million in annual recurring revenue, which could add up to $17 million in enterprise value to one of these companies. At 100 births per advocate per year, we could impact about 550,000 births by 2027, and Partumly advocates could be saving the health system $230 million through preventing those birthing complications that Mikhail and Dr. White talked about. Partimly can help make maternal disparities a thing of the past, but only with Optum's support. Optum brings the revenue cycle expertise, multiple referral streams across Optum's existing businesses, and Optum even has experience developing a talent pipeline for doulas through its work with Ladies of Hope Ministry, which has been training formerly incarcerated people to become doulas and give back to their community. Optum can set a new standard in making health insurance coverage for doula and health coach services universal. And Partimly is a social impact investment where Optum can demonstrate improvement towards health equity and economic development by essentially creating a new class of good-paying healthcare jobs with a low barrier to entry. We see Partimly advocates leading the field in documenting and acting on social determinants of health, which not only provides greater social support, but also feeds more advanced maternal risk models for the Optum Analytics suites. So this is us. You've got a doctor, a nurse, and a health coach. We combined our personal and professional experience to develop a feasible and scalable alternative to the status quo.
Can you talk more about why there's such a low volume of current doulas and midwives and health coaches? Is it a barrier towards credentialing for them? Or is it also not a very attractive job for them? Like there's no growth trajectory, there's not a lot of support towards the economics of what people want to get into that field per se. I'm just curious if you could talk more about that.
In the doula field, it's mostly cash pay right now. There is some demonstration projects with Medicaid covering doula services. The reimbursement is very low. And I think commercial reimbursement for doula services is very rare.
Yeah, and I would add to that. So there's actually 128,000 health coaches working today, but only those 6,500 are board certified. Once you become board certified, you can get that NPI number that then you can then get reimbursed for your services. So the health coaching space is a little naive for reimbursement, but it is growing, and this is an opportunity to help capture some of that as well.
Also curious if you are thinking of making any adjustments or if you find challenges with respect to current political situation in the US, because this also provides additional electronic track of people's pregnancies. And if they may have later complications and need help for those complications. So have you thought about it, or how are you looking at it and addressing it?
That's definitely something we discussed a little bit and something that we would need to explore a little bit more because with those changes in political views and everything, there are potential barriers, right? But we do see this really as a potential access solution.
And much needed as well, because again, this is going to be the glue that kind of connects the issue that we have with health equity and what we're going to do about it. And so this is just a foundation, and obviously we'll address any of those political issues that come up in the future too.
Can you just talk a minute more about how you imagine the joint venture between the startup and Optum working?
One of those companies, they exist now. What they offer is really limited back office support, so mostly some advertising, patient matching, and scheduling. They don't, well, especially for doulas, they don't offer any credentialing or revenue cycle. And so, we sort of have been going back and forth about whether this is sort of a co-branded joint venture versus just a strategic investment in one of these companies. And we kind of left the door open and went with our original branding for fun.
So we'll be starting today's talk with a patient encounter that we had. It started like any regular day in clinic. A patient named John came in for a routine annual physical exam. He did routine blood work, and it came back that he had elevated blood sugar levels, indicative of prediabetes. As we were trained, we talked to him about steps he could take to prevent the progression of prediabetes to type 2 diabetes. We explained to him that he should be increasing his exercise, limiting his carbohydrate intake, and trying to follow a Mediterranean diet. Before I could continue, he stopped me, and he looked up at me and he said, "Mediterranean diet? How can I control my health with a diet that's not even mine?"
More than 37 million American adults have diabetes, and another 96 million have prediabetes. These diseases have become true public health and economic crises. Type 2 diabetes is one of the leading causes of death in the United States, often leading to fatal complications such as stroke, heart attack, and kidney disease. Not only do these diseases affect the lives of millions, but they also account for 25% of all medical expenditures in the United States, accounting for a whopping 2% of our GDP. However, type 2 diabetes is preventable and prediabetes is reversible. Sorry. One of the main ways to prevent disease progression is primarily through lifestyle changes. The most important lifestyle change is a healthy diet. However, for many Americans, the road to health changes is littered by barriers and disparities. Access to healthy food and the social support required to implement this change are impacted by social determinants of health. Often, underserved populations are the ones who bear the brunt of these diseases the most.
So while lifestyle interventions are effective at reversing prediabetes, the growing prevalence of type 2 diabetes in our country signals that these efforts fall short. And so Peach Health aims to fill that gap through a prediabetes management platform that is patient-centric, and culturally competent, and specifically centered around nutrition. So food is more than just an important part of our overall health. What we eat and who we share our meals with defines who we are. And so current physician recommendations on the side of diet and medical nutrition therapies, they lack cultural competency. So therefore, they're often impersonal and impractical. So because food is critical in cultivating the diversity of our communities, there really is no one-size-fits-all diet to approaching and achieving glycemic control. So the 4 pillars of Peach Health are designed to improve the management of prediabetes through an intervention that will be culturally competent and patient-centered. All right, so at the core of our intervention, the cornerstone of our interventions are our registered dietitians. So our dietitians are not only certified diabetes educators, but they've also had the unique training of a federally funded, culturally and linguistically appropriate service. So it's a CALS education program. CALS education program, mouthful there. And the importance of this program is that our patients will be seen by someone who sees them. So the unique component of Peach Health is that our patients have the opportunity to choose the dietitian that they're going to work with on this journey to self-management.
Acknowledging that a lack of access to healthy food is often one of the largest drivers in disease progression, Peach Health offers members $40 a month towards high nutrition rated groceries. And leveraging existing resources, Peach Health partners with food delivery platforms such as Instacart to offer free grocery delivery, empowering members to regain control of their health through nutrition.
So navigating change is easiest when we feel supported. Peach Health offers its members access to a social network platform, Peachy Keen, where they can connect with other patients going through the program and also connect with past participants who have successfully managed their prediabetes through the intervention. In addition, they also have access to an extensive library of pre-recorded videos teaching them new cooking techniques and recipes so that they're able to sustain the gains they've made through this program. However, lifestyle changes aren't just about following a healthy diet. Countless behavioral, mental health, and socioeconomic barriers really influence the efficacy and success of any intervention. That's why our social workers develop meaningful and personalized relationships with our patients to identify individual barriers that they might encounter as they go through this program and help facilitate ways to drive empowerment.
All right, so what does the experience with Peach Health look like for a patient like John? So as an Optum Care patient, John's care team refers him to Peach Health after receiving a hemoglobin A1C level that is indicative of prediabetes. John will then have the opportunity to select the care team, the dietitians, the social worker that will work with him on this journey to self-management. And he'll meet with them to devise an individualized and personal approach and set of goals. An approach that can change over time as his disease and his life changes. Biweekly meetings with dietitians will allow John to embrace the role that food plays in managing his condition. And when he's not meeting with his dietitian, on off weeks, he'll be meeting with a social worker to identify and overcome barriers to lifestyle change, both tangible and intangible. Now, after a 6-month period, John will have his hemoglobin A1C re-evaluated. He'll then transition to monthly meetings, taking a little bit more independence in the management of his care. And throughout this entire process, John will be supported by a community of individuals along a similar journey. And he'll benefit from resources like grocery stipends and grocery delivery, improving access to nutritious foods. And upon successful completion of this program, John will have the opportunity to graduate on to be a health hero and provide mentorship to other individuals following this journey to better health. So not only will Peach Health improve patient outcomes, but it will also generate substantial cost savings. Existing research revealed that for a patient with prediabetes who goes on to develop type 2 diabetes, they face medical expenditures north of $3,000 per year compared to a pre-diabetic who does not go on to develop prediabetes. So taking Optum Care's patient population into consideration, we project Peach Health will have the ability to generate up to $355 million in cost savings over a 3-year period by preventing disease progression.
So we envision 3 main modalities through which Optum can deploy Peach Health. Like we mentioned with John, one way could be through billing it as a billable service through Optum Care centers. However, we think the most scalable approach would be by partnering with health plans, taking advantage of the patient population that Optum is able to cover. Not just those who are covered by United, but other plans as well. Thus, we envision Peach Health being stood up as either a fee-for-service model or value-based care model. And lastly, in the future, we hope to partner with employers to be able to improve the health of their employees, as well as to prevent unintended medical costs.
And then to stand up this plan, we envision a 4-phase approach, with the first 2 phases focusing on efficacy and feasibility. And then depending on the research there, the following 2 phases on improvement and expansion, with the ultimate goal of gaining recognition as a DPP certification.
So the bottom line is that prediabetes poses a massive threat to the American population. It's clear that this condition disproportionately impacts individuals in underserved communities. Through Peach Health, Optum Care has the opportunity to help millions of patients, just like John, manage his prediabetes through culturally informed lifestyle modifications centered on nutrition.
The theme of this case competition being, health inequities. I know something that's come up a lot, especially as healthcare services become ever virtual, telemedicine oriented. There's a big concern about technology disparities, right? So some of these, this population that you're targeting, financially unstable, under-resourced folks, maybe they live in rural areas where there isn't high-speed internet and they don't have an unlimited data service plan. And yes, they have a smartphone, but also the time they have to spend in, meetings with dietitians and social workers and all these things might be limited. So can you guys talk a little bit about any of the research and discovery you might have done within that population to figure out what they like what they have access to today, on the sort of digital side, and also in the sort of time and engagement through digital apps, like any research you guys have done?
It's a great question. And I think it's really important to acknowledge that oftentimes in trying to break down barriers, we might just be setting up some others. And so the study population in previous work on diabetes I took was actually in Atlanta. So we had a similar idea of standing up a digital intervention, and did research through Grady Hospital. So it's a large publicly funded hospital with primarily underserved individuals benefiting from the care. And what we found is that, like you alluded to, most people do have a smartphone, but a lot of times what the major barrier is downloading an app. And so one thing we've considered is instead of having to download an app, what's actually more effective is if you can send a text to open up a link and have it a completely online platform. So that's just an example of some of the research that went into thought here to limit those barriers there, yeah.
So you have sort of two models going on here. You have the nutritionist / CDE, and then you have a social worker. So what is the value of both of those when you were modeling this out? How much more incremental value you actually get out of the social worker? Because there's going to be a lot of costs there. And to your point, you're doubling the amount of visits and creating just another, I always worry about engagement with apps for all of the reasons that you were just saying too. Why both right now? What's the financial add there?
It is a digital app in which if you need mental health services, you can find any therapist or licensed social worker and connect with them when they're available. So we want to follow a similar model where our social workers and our dietitians would be on the platform like that. And the reason why we have both is because all research shows that while nutrition is important, what's even more important is the behavioral and the mental health perspective. So we can set out to do as much as we want to do as people and set goals for ourselves. But if we don't have the support and really someone helping us along that journey as an advocate, most efforts fall flat. We need to have a personal coach to push them along.
And I'm just curious how the dietitians on your platform be different from like other telehealth dietitians currently working the diabetes realm specifically.
Yeah. So the main goal there is that they are as effective as this current dietitian. So I'm sure you're familiar with DPP, so Diabetes Prevention Program. So you can have a qualification. We talked about CDE, Certified Diabetes Educator. The other certification that our dietitians will receive, I alluded to, it's the mouthful there. So it's actually offered by HHS, and it's a free program, but it's culturally and linguistically appropriate services. Sorry, it's a mouthful. Gets me every time. But so it's through this training. So it's a 5-hour training and also requires recertification where healthcare providers learn how to engage. So acknowledge their cultural roles and what they bring to the table and how to engage with others from others' backgrounds and use those as strengths. So that's a real key to our intervention there.
So many issues in patients receiving care is because their healthcare providers, whether that be through nutrition or through primary care, are not able to see them for who they are because they may not be able to relate to them or to understand the lived experiences that they've gone through.
And you also talked about free $40 and some
Instacart,
yeah, Instacart, right? So that's an awful lot, right? Can you just again go over the actual addressable population that you're targeting, and then are they being referred to your app via their PCP, and then is that going a prescription, and how do you generate revenue and then also pay for these other the sociologist or psychologist and dietitian?
Yeah, so we'll run through this quickly. So the model we presented was a patient seen in an Optum care clinic. And so we broke it down in terms of addressable population based on the prevalence of prediabetes, multiplied in percent of patients who report that they see a physician at least once a year. This was last year's data collected by CDC. That's how we got down to our total addressable population. They see down there at the bottom, 1.3 million people.
Real quick, just to inform the assumptions we made for patients enrolling in Peach Health as well as the completion rate, those were taken as average, what the base numbers were from the CDC's diabetes prevention program. So all of our assumptions have been evidence-backed by existing research.
And the assumptions are that we are going to be no better than that program, which we hope we beat. And so moving on to costs, adding in all these costs. So again, everything was rooted, so our $40 a month was rooted in existing research. So there's outstanding clinical trial right now going on up in Boston. And they're looking at giving $30 a month towards patients to have the exact same impact or study the exact same impact. And so it was in our model to add a little bit extra. The other thing that we wanted to beat is recognizing the plans through those who are dual eligible for Medicare and Medicaid to receive $20 a month in grocery stipends. So just seeing that it's it's a solution that exists and works, and healthcare companies pay for it. Finally, mentioned two models there, right? So the first one, the one we presented, is through Optum Care. So the idea there would be referring patients who are being seen in Optum Care's facilities. And there's a couple of different models. One would be a billable model, just like a billable service already exists, so in the healthcare space. Currently, the limitations there are that the billing codes are really only accessible to those covered by Medicare Part B. What we really see as the most scalable and impactful way to stand this up is through a model that Optum already uses in a chronic disease management platform. The idea here is your main target is health plans. So you're charging health plans either through a fee for service, so per patient base, rather fee per patient, to manage these risks, or through value-based. So establishing this cost care before you collect revenue. And we really think that's the way to stand it up. Again, so it's Optum offering a service to other health plans.
First, we're going to discuss our target underserved group, followed by our customer profile. Then we'll go more into our solution and discuss 5 issues that we are going to resolve for our target underserved community, and then go over timeline and cost. So I'll just pass it on to Jason to talk about our underserved community.
Our first actual task was to define what rural was. Generally, it's countryside and a low populated density area. Additionally, what we found out, various agencies, state and federal, have different definitions due to research and funding. So it made it a little difficult and confusing for people who qualify for different programs. As you can see in the map graphic, the darker shaded areas are where the country is at a shortage for a whole in healthcare. And I'm just going to pass it to Sahil for the regions that person in one of the regions that we're going to go into.
I would like you all to meet Patricia Brown. She is 67. She is from Delta region, which is a rural region. And she has been serving for military for 6 years. And then returning from the military to her hometown again. She is working to provide the home care to the aged community there. She also a breast cancer survivor, and she's personally feeling the healthcare facilities have been facing the issues there. These issues can be solved. These issues can be solved with our solution, payer to provider app. I would like Jason to talk about that app in detail.
So sure, for those of you who flew in today, you probably followed the same process we did to get from Pittsburgh to our hotel. We simply just took out our phones, opened up the rideshare app like Uber or Lyft, and requested a ride. So I don't think there's any reason why healthcare access can be as simple as that. Basically, our PDP payer to provider solution is a healthcare app that's going to connect payers and providers via a range of mobile clinics that's going to bring care directly to the customer, and it's going to be at the same level as make a brick and mortar. We're going to have a simple user interface for easy to navigate and keep costs low. This is going to be on-demand, real-time, where you can see different clinics and doctors that are available within the area. We're going to build this on a platform for Apple iOS and Google Android to access mobile and on tablets. We're going to keep connectivity as well for any guardians or family members who want to help any elderly patients as well on this app. All that's going to be done via secure authentication. Next slide. And we're going to provide in rural and remote communities, provide a variety of care options that you can see listed here, as well as services via different levels of care in different vans and shuttles and RVs, mobile clinics. So I think the main thing we want to focus on is execution on the implementation. We're going to use Optum scale and size to collaborate across the organization to bring this to life. We're going to use the existing assets. As you see, Optum already has mobile clinics. So this is nothing new to them, but I think using this new technology in partnership with the app will really bring it to the next level. Additionally, we're going to use Optum Care's network of physicians for the staffing. We really want to have partnerships. There's other healthcare systems that use mobile clinics as well, and we hope to bring that to life by partnering with them. Last month, Optum announced a partnership with Walmart, where they're going to have clinics. So we think Walmart has a really, really good strategy to target rural locations. So I think later on in the long term, our data from our app will be able to provide some insight into where brick and mortar locations may be needed in additional clinics. I think additionally, Optum's recent acquisition of Change Healthcare is going to be able to provide some of the insights solutions at the point of care and facilitate some of the payments. And, we're really going to quite literally drive this solution. And we're going to talk about some of the disparities next.
So as Jason mentioned, there are 5 disparities that we do want to use this app to resolve for our targeted community. The first being medical access to medical care and medication. Currently, there are multiple issues regarding this getting rural communities access to medical care and medication. And it can break down into 4 specific issues, which is lack of medical care or medical professionals in the region, long distances to just brick and mortar community or facilities, internet access. Obviously, rural areas don't have as much, and a lot of pharmacies don't necessarily accept the insurance of Medicare. So P2P would provide a solution in that it would consider the patient's insurance when connecting patients to mobile clinics and mobile pharmacies, as well as Jason didn't mention this, but we do also want to add a hotline option so that people who do not necessarily have access to internet can still phone in and use the mobile care network. And now I'll pass it on to Sal, who will talk about our substance abuse issue for our community.
Right. So, substance abuse is a continued use of alcohol and illegal drugs. So in the right side, you can see the chart where we can see the rural areas are having the high percentage of substance use. The issues faced due to substance abuse are limited resources for the prevention, treatment, and recovery. This can be solved with our P2P solution because P2P locates nearby clinics and provides the treatment, and also it access to the mental health professionals via mobile clinics and telehealth. So now I would like to call Jason to talk about veteran care.
Thank you. So veterans who often put their lives on the line for the country historically have received less than optimal care. As you can see here, there's a disproportionate amount of veterans that live in rural areas, with the main issues limited access to specialized care. And then there's additional factors such as homelessness, substance abuse, and poverty that contribute to a lot of the disparities. Our solution hopes to bring clinics and specialized treatment out to homes for these veterans, and then additionally mobile pharmacies as well, where they can provide medication, mental health care, and things like that. So I'm going to pass it to Smit, who's going to talk a little bit about hunger.
Yeah, so the chart here displays food insecurity is prevailing in the rural areas. And according to multiple studies, food insecurity is strongly correlated with chronic diseases and poor health. So, but some of the issues that rural communities face is lack of food retailers that can provide fresh and affordable food, and also the lack of awareness about right nutrition. So how P2P can help here is by connecting those people with the mobile markets that are nearby, and by also providing tips about proper nutrition, which could both be curated for local as well as seasonal advice. And these are some of the major conditions that prevail in rural areas. So P2P again here could help connect those patients with these conditions with nutritionists so that they can have a customized diet plan curated just for them. So now Shayan talk more about complexities with Medicare.
Yes, I just want to touch very briefly on complexities of Medicare. Medicare, of course, being the national government health insurance, there are a couple issues that really do need to be brought forth. One of the main ones is that because of the complexities of the sign-up for Medicare process Part B, there's a lot of issues that eventually lead to penalties being incurred by citizens, higher out-of-pocket costs, and unfortunately, it does take up a lot of time, emails, and calls for the Medicare Rights Center. In addition, a lot of the medications all the household spending for medications for Medicare patients aren't usually covered because these are usually generic medications. How P2P helps in the situation is that we make a more streamlined startup process to help people sign up for Medicare, to decrease calls and emails to the Medicare Rights Center, but also by bringing forth low-cost, affordable medications to the forefront to the citizen. We do want to round out now with our current timelines for the P2P application of the costs. We actually split up our timeline into an initial 6-month pilot program that's going to funnel into a 5-year plan. So our 6-month pilot program starts with partnering with Optum Health and companies that already have mobile clinics on hand that we can actually use for some of the clinics that were already discussed by my colleagues. Next, in the connecting phase of the pilot program, we would recruit the necessary medical physicians, nurses, and healthcare staff to run the mobile units. Moving into the product development, which is the third phase, once the P2P application is developed, we would actually introduce it into one state in 3 separate regions to gather all the necessary data and information that we need. And once we've gotten all that information, we would funnel this into the 5-year plan. The 5-year plan does begin by building on the existing networks, the existing Optum healthcare network that Optum has. Following this, we would recognize synergies and complementary goods that the mobile clinics already have. For example, I do know that Optum does have the Rally app, which is also up and running right now, which we could use in conjunction with the P2P application. Combining the advertising of Optum Health and United Healthcare, we would be able to bring this to the market. And after we've collected the necessary data that would help us enhance our user interface, we could actually use this to enhance the care at the rural clinics. I'm now going to pass it to Sumit to sum up the costs for the P2P application.
So the markets that we are trying to penetrate here, the mHealth and mobile health and the telemedicine, both have compounded annual growth rate for more than 25% for the next 5 to 7 years. That puts telemedicine market alone at $400 billion by 2027. The solution, the all-encompassing solution, isn't that heavy on the cost. So the cost of building the app is $50,000 each for Android and for the iOS. But we would also like to add a hotline to it, as Anju pointed out, so that the people with lack of internet access and who are not that tech savvy could also use our solution and the benefits that our services provide. So that brings in additional cost of around $55,000 per year for staff. So, but the beauty of this is, like, when we go from pilot phase to the deploying into the larger scale, then the costs incurred are not that high because we are leveraging technology in this. The only additional substantial cost would be of the staff, but increasing staffing costs would only be indicative of increasing traffic on our platform, which I think would be good news.
Yeah. And we just want to thank everyone for coming out. We know it was a long trip, but we're opening the floor to any questions that you might have.
You're clearly targeting rural individuals. Have you thought about, what would be the perception or reception of a mobile truck rolling into a town without any local partner someone that's trusted by the local community to, endorse that service?
Of course, there could be an initial backlash, but rather than just simply starting Optum Healthcare, we would be going to hospitals, for example, in Pottsville, Pennsylvania. There's the Lehigh Valley Network, which services a town of about 3,000, maybe even less, partnering with the hospital and with Optum Healthcare together. So it would be part of, if you can go back, we would definitely bring it up in 6-month pilot program as we're recruiting the necessary healthcare staff, hospitals, nurses, doctors, and the institutions.
Can I just like clarify some of my understanding here? You guys really want to build an app that locates and identifies resources that might already be available, like Lehigh clinics, right? Or something like that. You're not planning on spinning up and operating your own mobile clinics, or are you?
No, we would be.
Okay, got it.
Right.
So I do have those sort of like basis of understanding, make sure I got that right. So to what extent have you guys kind of thought through the logistic realities of scaling that? You know, a lot of health systems even have trouble creating their own clinic locators because, you know, clinics open and close all the time, or getting the data sorted. Like, you're now working with a bunch of discrete external partners. How do you sort of manage that from a logistics standpoint?
And they move.
And they move. They move. Right. My local brewery can't even keep track of what food trucks are where, you know, like, so what about sort of the logistical challenge behind identifying all these, keeping track of them, keeping the data current?
Yeah, no, the initial thought would be similar to how, you know, Uber drivers accept rides, things like that. The clinics themselves would have their app set up, accepting and having their location on, knowing what's available, what services are available, what type of care that would be provided there. So they're going to be in charge of kind of turning on and off, you know, whether they're available and where they're at.
So you talked about veterans, substance abuse, food access, Medicare enrollment,
Pharmacy.
What's the number one issue facing rural communities if you had to pick one thing from the data that you curated? And second question is, what's your definition of rural?
15% of the population. So what we're trying to look at, we use that map and the data that we had to pinpoint different locations like the US-Mexico border, Appalachia, tribal communities. Those were kind of our target locations. We were going to slowly roll that out to those areas. I think based on the data we've seen, that's kind of where we want to pinpoint rural. Again, it's very broad. There's a lot of data and research out there that's done and programs that are available based on the definitions through these different agencies. So we kind of want to pinpoint one of those regions.
Then that's, you think, is the most important for rural,
The most,
given that it's such a broad definition. of
right. The
rural.
most important issue is just the simple actual lack of basic preventative care after time in primary care. If and for example, I can use possible Pennsylvania just from the top at being there recently, you have maybe one plastic surgeon covering the entire area, only a few doctors and nurses, but at the same time, there's no clinching reason to keep them there. They're going to go where, unfortunately, in many cases, where the money is. And it's not going to be in those areas. Lack to that single internal medicine doctor, lack to that nurse practitioner is going to drive down the entire care community. So although internet access might seem like the primary problem here, we did add in the hotline that would eventually circle back to internet access. But from what you're saying, no, it's definitely the lack of preventative and primary care just in general. Thus, bring mobile clinics to these individuals who, I guess the second problem here is actually lack of education, both in technology and in terms of their own health. A coal miner is not going to understand that in many cases that his lungs are being affected by the area around him, or someone working with asphalt in many cases going to make the simple connection. I need to go to the doctor. I can't find one. How do I look at my phone in some cases?
So this is a kind of further down the line, just this question we had. And please correct my lack of understanding, but I think the scaling issue is just workers. We're in an acute worker shortage crisis in the whole healthcare industry, like 50,000 doctors, over like 200,000 nurses, and other providers. So if this is really tapping into the existing assets that we currently have, like if they're so understaffed over, there's no capacity to be had, how do you think to address that if it's going to grow, if there's such a huge lack of existing and growing workers?
We did work with an idea initially regarding also student loan debt for doctors and nurses, which, to be honest, every doctor and nurse has a little bit of that debt. Where working with these mobile clinics and with Optum Health, we can actually help pay a little bit for their loans, somewhat similar to the student loan forgiveness program that the government had, but in this case, bring that forgiveness through the mobile clinics to the facilities that need them. And at the same time, we actually thought about, again, given the shortage, some sort of rotational like program working with hospitals that we can bring those doctors to those communities. Lehigh Valley is an example, just from my recent memory. But yeah, those were two solutions that we came up kind of short term. In terms of bringing more doctors and nurses into the healthcare in general, that's going to be something that probably is out of the scope of this solution. But those were the two initial things that we actually had.
When we picture a woman who is pregnant, we often picture her from a variety of different experiences. She can be rich, she can be poor, young or old, but oftentimes we picture an abled woman as a woman who's pregnant, and pregnancy is not something that we picture for someone who's disabled. Our team was looking at gaps in maternity care for the differently abled, and we found that even though pregnancy is one of the most statistically normal biomedical events that someone with a uterus can experience, for disabled women, this is often treated as an anomaly. 1 in 4 women have a disability in the US, and 10 to 12% of women from a childbearing age have a disability. And even though disabled women get pregnant and give birth at the same rate as abled women, care and health outcomes for this segment are drastically different. So if you look at health outcomes, there is a 29% higher maternal morbidity rate for this group. And we see an increased risk of complications, not because of the disability, but a result of not getting appropriate care. We looked at understanding the gaps across the social determinants, and we saw that there was a lot of inequities in terms of getting access to education, the quality of information that's available, building communities, and healthy environments. So here is Emma. She has a rare autoimmune disease that had where she endured a spinal cord injury at the age of 10, and she's been in a wheelchair ever since. So when she finds out that she's pregnant, this is a joyous moment for her, but she goes to an OBGYN that a friend recommends, and she is labeled as a liability and refused care. So now it's in Emma's hands to sort of become an advocate for herself, find the right provider, find the information, and prepare for delivery. Her labor and delivery is also not without complications. She has a C-section, and postpartum, it's hard for her to find the right resources and care for herself and her newborn. Emma's not alone. From our research, we found that almost all women suffering with disabilities have a really hard time finding community and connecting with other women who have gone through the same thing that they have. Also, the resources that are available to them are usually they're the same resources that able-bodied women get. And as this person writes here, everyone wrote me off, so I wrote myself off as well. There is a lot of anxiety, and they feel that clinicians were less knowledgeable about their specific disability than they would have preferred. They experience a lot of loneliness. There's a lot of negative stereotypes associated with disabilities, and so they're reluctant to ask questions and seek care at the right time. And also, because they don't have adequate information about how a disability can affect their pregnancy, there's a lot of fear. Also, in terms of complications, this group is at a higher risk for adverse maternal outcomes. During pregnancy, during labor and delivery, and also postpartum, there's a risk for complications. So we looked at how we could create impact and what are the opportunities to help this group. Obviously, by early intervention, we had the opportunity to reduce mortality rates in this group. By intervening early and even before someone gets pregnant, we have the opportunities to set up a course of action for how that pregnancy could turn out. Also, there's a better awareness that we could create by talking to these women early on and giving them the right resources. And we can also reduce the number of emergency room visits. We found that in this group, women tend to visit the emergency room almost 12 times more than abled women during their pregnancy. So we looked at how we could inform and foster inclusive environments for pregnant women with disabilities to create systemic changes in their healthcare. So our service is really looking at a two-pronged approach. We're looking at something that will target the patient as well as the provider. We want to create a community for pregnant women with disabilities where they can share some of their anxieties, get feedback from providers, and also connect with other women who are sort of going through the same thing that they are. And also from the provider end, we found that there is a lot of lack of knowledge. And so we want to collect all this data because there is so little data about this group. So we can create standard practice guides. And by sort of by having this two-pronged approach, we're able to connect this group of people with all the different resources and tools that they can use to have a successful pregnancy. So like I mentioned earlier, we want to help patients find the right provider. We want to give patients the access to resources because it's hard for them to, usually what people do is they'll look online and it's not really a credible source. We want to build communities.
And the provider will get a standard practice guide that will be made by collecting data on this group. So we'll have evidence-based outcomes for how to deal with different disabilities. There we see like a huge need. In a survey conducted by Dr. Liz Lazzoni and Amy Wint, all women with disabilities expressed a need for better information to guide them through their pregnancy so they can make critical decisions about their delivery. And also from a provider end, there's a huge need to have more information because we found that 1/5 of OBGYNs, less than 1/5, actually receive training on care for women with disabilities. So the impact of sort of giving them access to information, creating that awareness means that we'll have decreased complications during pregnancy, labor and delivery, and postpartum. We're also giving clinicians better guidelines and practices to follow so that the care is equal amongst all these groups. And how can we measure this impact over the next 5 years? We can look at the number of emergency visits in this group, the number of pregnancy-related health complications, and the prevalence and development of preventable health conditions during pregnancy. As I mentioned, this is quite a big market size where we have 36 million women with disabilities, and 10 to 12% of that's around 6 million have disabilities of childbearing age. And we decided to look at women with mobility disabilities as a focal set, and there's around 720,000 women who are of childbearing age with mobility disabilities. So early access to care, again, means reduced costs. These are just some of the costs associated with complications during pregnancy versus what it costs for like a healthy delivery. Some of the costs that we have is to set up a hosting platform, collecting the data, designing this platform, preparing resource guides, implementing the framework across different clinics, and then outreach. So from the data, if we consider 5% of our demographic, we're able to triage this patient to the right OBGYN and reduce 10% of the cost due to complications. We can save approximately 36 million. Some of our strategies to bring this to life is first to identify a target user group. So we'll be looking at women with mobility disabilities first because they're the most prevalent. We can ask these women what they'd like to see, collect data, design this platform, adopt this framework across different clinics, and then have a pilot test to get insights from real women and make iterations. And then pre-launch, we can curate participating hospitals. We'll be able to see where this framework will be adopted, launch our website and resource guides, and then market the product. So pregnancy can be a really stressful time, even for like an able-bodied person who has a healthy delivery. For disabled women, this can be even more stressful. So we're here to sort of help alleviate that stress and create a positive experience. This is our team, and thank you so much.
To make sure I understand what it is a patient-facing platform where they have a group that I assume someone would kind of watch or curate so they can share.
Yeah, exactly.
And then a guide for providers to go to.
Curating the right information for these patients so that they feel more at ease because there's this huge lack of information for them because all the resources that they get are aimed at able-bodied women. And then from the provider's end, we notice that there's like a huge lack of data because not many times this data isn't categorized or collated anywhere. So we want to essentially create a repository of data and then use that data to sort of form the standard practice guide.
So it seems that it's self-service. There's not a care coordination advocate.
No, right now, for now, this is just sort of the initial service idea that we have. And obviously this can be scaled up for other disabilities. We're looking at mobility disabilities first. This is looking at maternal services. There's also the same gap in access to reproductive care for this group. So there's lots of ways that this can sort of be scaled up.
Is anybody paying for anything here, or is this a free resource for patients and providers?
We're looking at this to be like a free resource for patients and providers, yes, because we'll be saving costs just by intervening early, and that's really the way we're assuming this would work, yeah.
So how would it be funded?
We see that like from the amount that we're saving in their complications, if that money is sort of put into developing this, it is self-serving.
Whose money are you saving?
If so, a person from the insurance company where all of these expenses are essentially going to be paid. When we sort of put in the costs that we're saving into developing this platform and these resource guides, it's sort of a self-serving platform.
It seems if you do this in the early pilot stages, you probably want to pick a city where the patients and the providers in that system are aligned. I'm trying to think about how it scales if the people aren't necessarily where the aligned health facilities are and how you in the early stage, keep them synchronized, because if you're really dependent on those two halves of the model working together, if they're in disparate places, then you're going to have a lot of frustrated people.
Right, right. You're right. And we sort of wanted, when we looked at some of the ways this could go, there are a lot of initiatives locally in terms of there's lots of gaps in access to care. There's lack in like transportation. There's lacks in midwife services. So essentially this resource guide is just sort of summarizing what someone can access in their community and then sort of connecting with them. But right now we see that there's a gap because women are unable to find that information locally, online, and it's basically causing them to receive care at a later stage where there's a higher risk for complications to be developed.
Our solution to the mental health crisis faced by young people across the nation. I want to give a trigger warning before we go to our next slide. What you're about to see serves as a reminder for why we can't wait any longer to deal with this crisis. Headlines like these represent the harsh truth that our children face across the nation. How many of us recall hearing about a neighbor going through a mental breakdown or a classmate that's going through a crisis leading to suicide? We see these every day, headlines and stories, and it doesn't get any easier. We're desensitized to these tragedies at this point. Even worse, they only scratch the surface of what's really going on. Young Americans every day are facing new pressures, academic pressures, financial struggles, facing new responsibilities with adulthood in a struggling nation. Over the past 2 decades, public health campaigns have helped to destigmatize these issues in mental health and beyond, yet we hear of these stories far too often. Let's take a closer look at the scale of the problem we're dealing with. So this map tells us a lot, similar to the map from our last presentation, but this is specifically for mental health. A vast majority of counties in the United States lack adequate access to any sort of mental health professional. McKinsey reports that over half of counties in America don't have a single psychiatrist. A single psychiatrist. Among college campuses, 60% of universities are struggling with turnover for professionals dealing with mental health issues. And 70% simply cannot recruit the right amount of professionals. This amounts to the startling result where 4 in 5 patients referred for mental health care don't receive that care. This data goes to show how isolated our patients are from the care they need. And even worse, young people are speaking so openly about these issues these days on social media, out in public, but the opportunities, the door to adequate treatment stays closed to these patients. Let me introduce you to one such patient. This is Naomi. Really, it's an AI image. This person doesn't technically exist, but we see her as no one who represents anyone. And her story is complicated. She comes from a small town in rural Pennsylvania where she struggled with bullying and feeling like an outsider. And she needed help. She got good support from her primary care doctor, how to deal with the stress, how to get through the day. However, she's in college now. She's hours away from home. She's away from her family. She's away from her old friends. She's away from her medical home. Naomi is alone, an outsider, once again in a foreign land. She tried calling on-campus counseling, but the waitlist was for weeks. And she tried downloading an app, a mental health app, Headspace, but it just wasn't enough to read through the prompts and complete the tasks. She needs a viable mental health service now. And that's where we come in. John?
Optum Intercare is a platform as a service, and we're focused on the behavioral health of our college students. From the end user experience, we see that students will be able to log into Optum Intercare at a telehealth kiosk, at a computer, at a tablet, on their smartphone. And on their first visit, we want students to fill out a brief survey regarding their mental wellness, provide their communication preferences, and be matched with a provider to begin their therapeutic relationship. So why is matching a client to the provider important? As we mentioned earlier, 4 out of 5 people diagnosed with mental illness do not receive mental health care after being referred. A primary reason for this referral to service gap is due to the amount of hoops that a patient must jump through to be able to see a provider. Questions that may arise are like, will this be covered by my insurance? Is this person accepting new patients? How many sessions am I supposed to go to? And is this even the right therapist for me? We leverage a proprietary algorithm to match patients with a compatible provider in the Pennsylvania Health Network. And the cornerstone of this algorithm is a 3 or 10-minute personal identity questionnaire, which then matches to a provider of a similar identity, should that be the patient's preference. The time to enter the market is now. Year over year, investing in revenue in this space is doubling. Over $550 million was invested into digital behavioral health over the first half of 2020. And there's growing competition. This is a fast-growing space. Companies like Ginger, Doctors on Demand, Teladoc Health, and so many others have already existed and are thriving. In 2022, there have already been 86 new entrants into this market that have started to receive early-stage funding. So we've designed our platform as a service with a strategic position to address a broad set of needs for many patients in a narrowly defined market, positioning us on the productivity frontier and maximizing our return on investment capital. Specifically, our college-age patient demographic is unique and has unique needs that aren't being met. We offer to reduce university overhead for their mental health services. We want to leverage the internal capabilities that already exist within Optum. They have a telehealth network. It just doesn't have behavioral health products from my understanding. And we want to advance upon this. We want to introduce incentives for virtual health activities, and we want to offer a quick and tailored questionnaire to match our patients with a provider that could help them through their mental health crises. What's more, we also want our model to introduce incentives for virtual health activities with a broader movement towards value-based care to save more money at the aggregate level, because emergency mental services are very expensive. There are large backups in terms of inpatient psychiatric needs, and it's a very costly amount of money for the health system, as well as at the government level and at the private insurance level. These activities give us a unique and valuable position, offering a sustainable competitive advantage in the market based off of Optum's expertise and large provider network. Our financial model projects invested capital to launch our platform as a service at only $55,000 if we were to leverage Optum's internal capabilities, or $200,000 if we were to use outside resources. Our timeline includes 6 months for app development, time to negotiate with colleges and universities to find our best fit for this project, and kiosk construction for our telehealth services so patients can feel comfortable at a space that is not their dorm room or in a busy closet. We want our beta launch to be in the summer semester of 2023, so we're perfectly in time for the new fall campaign in 2023. We'll roll out our platform as a service and kiosk at one campus and scale up our operations across Pennsylvania and hopefully eventually across the country. By bringing the provider to the campus through Optum InterCare, college students like Naomi can avoid the delayed wait times and the progression of their mental illness. Furthermore, we can intervene before students drop out of college due to mental health issues. This will decrease the cost to society and maximize the opportunity for our patients. In this way, Optum InterCare both reduces the harm that patients experience through the traditional referral process and provides cost saving compared to potential hospitalization due to the psychological distress.
Who is your target customer? The university, the college? Would they adopt your platform and make it available to their students?
Yeah, that's ideally what our customer would do.
Yeah. They would subscribe to your platform.
Yeah.
And then advertise to students.
Yeah.
Then what is the cost to the student?
So usually a requirement for universities is for students to have an insurance plan. So whatever their insurance plan, whatever their copays would be, if they're using the Optum platform, that's how much the cost will be on the student.
How is this not just BetterHelp? Right? Like, are you familiar with that platform? I mean, it's almost exactly this. So I guess I'm wondering how, compared to that. I think Talkspace maybe is another one that's similar? What's the differentiator there? Or are you just, another option in that space?
Yeah, so I guess our primary thought on that is related to the pre-existing size of Optum. It has a telehealth service. And from what I understand, United Health Group is a large insurer for a lot of universities. So this could potentially be, I don't know if you're familiar with the idea of like a walled garden. People will often describe Apple products like this. So you buy one Apple product, oh, you like iMessage, how about use it on your computer? So you keep on buying these services. So say United Health has a deal with a university and our Optum InterCare is able to provide the mental health services, because this is a lot of overhead for university. They're having trouble maintaining staff. And it's just overall been a more in-demand thing due to the mental health crisis that COVID has precipitated. And also the mental health needs that many of our students are more aware and feel comfortable seeking out. So we see that United Health insured schools could potentially use this as a way to, if the service works well for the school, they can maintain their relationship with or United Health and continue their insurance coverage with that insurer.
Is the differentiator the kiosk, or is it this matching questionnaire, which I assume you haven't validated to see if it works? But what is it that sets it apart?
Yeah.
I mean, I get the market piece, but it has the risk of saturating just like any other mental health product. That's almost like a given. So how do you, what is different about this than something like BetterHelp?
Yeah.
We talked about a few different features.
Dan, do you guys want to speak?
Yeah, so we really tried to refine the strategic position to make both the survey questionnaire shorter than what's already existing in the market. However, not failing to recognize what people find to be their most personal identity traits if they were to want to be met with one of those types of providers. Additionally, we don't only refer our patients to physicians. We also refer them to whoever their should most be paired with. So it could be a mental health counselor, could be a psychologist, psychiatrist, doesn't always have to be a physician. So we're referring to a broad array of professions that are within Optum's network. We're also targeting very specifically consumer segment, the college-age population. And a lot of these other apps, every other app does not specifically target one age group and demographic. So a lot of, at least college students, they might be afraid to even pursue these resources. They might not find them to be cool. They might find a lot of pressure in using them too. So I think that what we've discussed and what we've looked into is if we're able to market this product specifically toward this age group to make it something that they find relatable, to make it something that they're not afraid of, to make it something that their peers are talking about, that they know they can go to, all of a sudden, we're able to kind of separate ourselves from all the other players that are in the market. Like we talked about, already 86 new entrants that got early stage funding just in the very beginning of this year. There's too many options to choose from. You go into your app store, there's so many apps, but if your college is marketing this to you, this is the resource that we have that you're going to use. It saves a lot of headache for the student, and ultimately creates a barrier for them to get this care.
So you're talking about steerage, right? Personalized steerage to some extent, or actually quite a bit. And the questionnaire, you're saying it's a very simple questionnaire, but that's kind of contrary to something personalized. You need to have more information about that individual to make sure you're steering them to the right person. So have you really thought that through?
So we had also taken into consideration that if a patient wants to fill out a shorter survey, then they might not be interested in matching with someone that uniquely identifies with who they are. They just want to talk to someone quick, as fast as they can. But if they are seeking something that's more personalized, we'll use one of the research-backed questionnaires that's already published in the literature that a lot of the other platforms are built upon. And that's our 10-minute questionnaire. But we want to leverage that as well with consumer surveys from this patient population to figure out, you can ask them every single question in the questionnaire. What are the questions? What are the identity traits that they find most important, that they want to be connecting with people on? Because you can ask them thousands of questions, but ultimately we want to get it down to something that's quick and doesn't lose the attention span of a patient that might have ADHD. When they're filling out a survey, by the end of it, they have already lost their attention and they moved on to something different.
And then who reviews those responses? Is that a professional? Like who makes the decision, or what makes the decision?
Yeah. So this is more so about leveraging AI and trying to figure out, after a provider, any one of these types of counselors has filled out their survey as well, the 10-minute questionnaire, you figure out which are the most similar. And the best example I'd have is if you apply to be an intern at Google, all of the Google teams also submit the same exact survey for what they're looking for their team. And ultimately, they use an AI matching algorithm to figure out where people belong that are most similar. And we'll leverage the same type of strategy in regards to this matching.
And the cost of the visits, you said, would be billed to insurance, but in a lot of kids are on their parents' insurance. So have you thought through the uptake issues around, because there's going to be a bill or a statement of services that ends up in the parent's house. So have you thought about alternative payment models other than that would make this work? Because otherwise people might not sign up for it.
Yeah, we think that it's critically important with these virtual health activities to step away from the fee-for-service mentality and reimbursement parity and try to go into something that, United Health might be able to offer, like discounts or incentives for patients that are pursuing these types of virtual health activities, so that it could, for one, be free to the patient at that time, with United Health knowing in the future they won't be back seeking their services, ultimately driving up more cost to the system. Or it could eventually be a patient that really enjoys the services that we provide, ultimately going into a monthly payment plan, where still United Health is offering a discount to that patient with a little bit of revenue to offset some of the upfront costs from the discount to the patient. In the end, saving, costs to United Health as a greater organization if one of these patients was to have to go seek psychiatric emergency services, be admitted inpatient, or also the cost to society as well. If the patient drops out of college or they end up killing themselves. The other aspect to this is colleges and universities have an incentive here as well, that if these students stay admitted in their schools, ultimately it drives up their revenue. So United Health is an opportunity to negotiate that into contracts with these universities and colleges to try to get reimbursement in that regard.